Welcome. I want that. Great. Jim Mulshine, back for the final breakout discussion. We have two breakout groups. Rowena and I will be working on the clinical, and we have Rick Avila to help us with the technical. And I want to thank everybody for the resilience in surviving this long into the workshop. I think we have had a really vibrant discussion, so we have a lot to talk about, so we'll try to jump right in. Is there a problem? So the clinical breakout group, the title was Getting Serious About Public Health Impact of Thoracic CT Imaging. And we had the benefit of a conversation yesterday, and we've had ongoing discussions as we move through the workshop. So we had a series of questions that we posed, and we had interactions for the group. And we put this together, and this is too busy a slide because this is a workshop. And so what we try to do is capture, the essence of the feedback that we got in the conversations. I'm going to walk through it. We're going to try to distill it down to what are the critical action items, which if we work on those things over the following year, we can do the most to advance the field. And we want everybody's input. We have people in the Zoom, and you can communicate through the chat. And as we get into the back and forth, potentially you can also come on live and we can work through that. So without further ado, first question. How do we advance the message that lung cancer screening is an internationally validated life-saving service that should be urgently embraced by the public and medical community? Now, there was enormous amounts of discussion about what is the actual benefit and harms. And I'll just say, for the sake of this closeout discussion, is that the correct answer is it depends on who you are and what you value. And so we've gotten survey information, we've gotten recent publications that show different individuals think different things are important. And so I think the message for us is that we have to have a very, a flexible response that is tailored to the community that we're dealing with at that point in time. And more will be said about this as we go through the discussion today. If anybody wants to add anything, they have a burning comment, please let me know, or send in something through the chat. Rowena is going to be monitoring that, and she'll bring things forward as she sees them. The next point is planning for a workforce ramp up. Now, what's the issue here? People were talking about, how much work it is to get a patient to get a subject into screening, how much problem there is doing all the scheduling and this, that, and the other thing. We're going to talk about some of that stuff. But that's right now at a point when we're at, 10% implementation of the target group for screening. And so if we're thinking about, over the next couple of years, getting closer to, higher levels of participation for eligible patients, there's a real workforce need in terms of radiologists, advanced practice nurses, pulmonologists, whatever. And it seems like that's worth some kind of consideration now to start doing some back envelope calculations of what might be needed in terms of stepping up training and professional preparation, and dealing with some professional societies that in relevant areas to talk about how we get that workforce for 2025, 2030 in place so that we can meet the needs of all the people who could benefit from screening. I will say one other point about this is that we've heard eloquently from several presenters that, for instance, there's considerable bandwidth deficits in the primary care community, and that they have enormous challenge just doing what they need to do from their perception in terms of cardiovascular health, taking care of high blood pressure and diabetes and stuff like that. And they just don't have time to add anything else, including lung cancer screening, into that workflow. Well, it's a very important issue. And I think that's a manifestation of burnout at some level. And if we don't kind of engage with PCORI and other professional societies to start working at this workforce problem, it's going to really hurt us as this field starts moving forward. And there's more acceptance in the public. Okay, then we talk about the understanding what is valued by screening individuals. And I've already touched on this a little bit, and there is some redundancy in these lists, but people pointed out that some people want to avoid getting lung cancer, other people want to be healthy, other people want to avoid heart disease or COPD. Other people said that no, there's kind of a pushback on the part of individuals because this is too many diseases, too complicated. They don't want to know. So there's complex issues, and we have to be very careful in sorting this out because this is the reality of what we're dealing with. And so we appreciate everybody's feedback in this regard. In a dialogue that I was involved in with Ella and some other people with CMS regarding the first national coverage decision and then the second coverage, the revision, the recent renewal of the national coverage decision with the extension of eligibility with CMS, we had discussions about the amount of screening barriers that existed. And from the CMS perspective and talking to the U.S. Preventive Services Task Force, they said, we do not read articles talking about barriers to screening. And in fact, we think shared decision-making and all these other things are very important. And we see a lot of positive benefits, but we do not know, we're not aware of these screening barriers that you're talking about. Well, Javier's not here now. And I hope he, doesn't mind me taking his comments. But basically, Javier is as earnest an advocate for screening that exists. And he pointed out that, his institution in Spain has put on 10,000 people in screening over the last 2 decades. And he says, when I think about referring a patient for screening participation now, he gets palpitations because he knows what a headache is going to be. And he almost doesn't want to do it. Well, if our most earnest advocate is afraid to refer people for screening, we got a problem. So what we need to do is have a Leahy or other institutions, start putting stuff out in the literature about quantitative dimensions and the professional barriers in this regard, because this is a big one, right? So we'll keep moving. PCPs we've already discussed, and they are a canary in the coal mine around these workflow issues. And so we'll just move on from there. But conversely, the other message we heard, and this was from Mary Pasquinelli's feedback from her work that she talked about last year and has talked about in other forums, with the way that they approach screening, their communication back to the patient is a real strength. And they think that it really engages the patient, especially having the time to go over the scan with the screening participant and their family to explain all those things and talk about it in terms of their health journey. And health journey is a word that emerged off one of the slides. And I think instead of health check, the concept of health journey, thinking about all these things, not as neurotic kinds of things about what's going to get you today, but a journey in terms of you being in charge and controlling your health. I think that's a very exciting concept or terminology. Okay. So there's other issues that we heard about in exquisite detail from the population health discussions, in which there's this incredibly complicated series of structures around pre-authorization, reimbursement, crediting the proper professionals for services that are essential to, a well-developed screening service. And there was a concept of sludge that was raised in characterizing this whole gamish of stuff. And fortunately, we had some experts who had some insights into how we could do this more productively. And we'll come back to one of the action plans that arose from that discussion. Okay, next question. How do we communicate the importance of AI related tool development and the importance of donation of data that is fundamental to validation of these important tools to allow them to make sure that they're doing the job we want them to do. Now, in the very last session before this, we heard a discussion about the timeline for AI development. And is it 5 years? Is it more than 5 years? And one thing that kind of came out of all this stuff is that the biggest bottleneck in the pace of AI development is the lack of availability of ground truth image collections that can be used both to develop the tools and then independently to validate the tools. And it's the people in this room and the people on the Zoom call that control many of those cases. And if there's not some kind of mechanisms that we can come to for sharing of cases with these databases for this critical tool development, it won't be 5 years. It won't be 10 years. Even Google has a hard time getting these cases. We heard from Dan. So we've got to spend more time thinking about consortial contributions in that regard. Talked about workflow a bit already.
Jim, can I say something?
Sure.
We say that every year. I'm not trying to give you
I mean it. This year's different. No, but it's now every year it has more consequences, right?
I agree, but what are we going to do different?
Any thoughts? Well, I'll tell you the positive things that I think are happening we work with QIW with a small nodule profile in terms of making tools to facilitate this. It's a pre-competitive environment where we're doing this for the field. We have people like Artit who are putting together critical image collections that are going to be critical in terms of, is AI measuring 5 millimeters the same across all these systems? Are these other collections with David and Artit where they have zero growth, where they have multiple cases where the same tumor nodule of different size and different location has been visualized on a couple of different CTs. And so it's known to be zero growth. And these collections we're potentially putting together as a resource to the entire community so that at least at that level, these tools are working on real world data and coming up with similar conclusions. You're talking about putting together comparable image cases from the phantoms. And that stuff is really quite arcane, but it's essential. So we're doing that and there's progress on that. So that's one thing that's gotten better. For the image collections, I think hearing about if progress has been made in the Phoenix VA is beautiful. And if places like the VA could potentially want to contribute to this, they could be an invaluable source of ground truth in this regard. There's other systems and some of the systems that, David, you're talking about developing, the same thing. We could make donation of some of these or some fraction of these cases a constitutive part of the activity. If anybody has any other solution, please let me know, send emails, whatever.
You heard Andrew McKee say that lady has 10,000 cases, right? How available are those images?
25,000 scans.
25,000 scans, 10,000.
With ground truth.
How available are they for anybody to use?
I mean,
I'm not saying you should be or anything. I'm saying it's not easy.
no, they're there, and the reports are meticulous because every single one of those scans was read out using lung rads and with really very disciplined QA, because Brady was just crazy about auditing the charts and auditing the scans
so
and the
I have a-
reports and making sure the language was consistent. But
Quick question. You don't have to answer it right now, but how much money would it cost to just take all of them and make them publicly available?
they're not my scans.
No, but
Leahy's
let's
scans.
say it costs $2 million. Let's just say it costs $2 million, right?
You'd have to
Okay.
go
So
through
we-
IRB and regulatory issues.
I bet you we could raise $2 million.
So the other thing I want
Well,
to say is,
I'm
go ahead.
getting together with a bunch of Leahy people tomorrow. I'll ask them what they think.
Paul
Going for a
Pinsky,
bike ride.
Paul Pinsky was here yesterday, and one of the things he's doing at the NCI is working on a new contract to collect images that the NCI is going to make available through the
Oh, yeah.
TCA and through their NCI supported image collections. And so I think,
We already have made a lot of our scans available to NCI. We did that a while, years ago, but there's a lot more scans now.
so let's continue this discussion offline because it's critical and we can't do justice to it all right now.
Okay.
It's absolutely fundamentally important. Thank you,
Hmm.
Andrea.
So
Can
Jim,
I go back? Are we
Yeah.
discussing these things yet? Like, or are we
Yeah, go ahead.
going to go through all of this and then
No,
discuss?
no.
So can we just go back to slide 1?
Yeah.
Uh-oh,
First line.
we're going to be here a while. Can you?
No, I'll be brief.
Just kidding.
As long as we can get back to slide 1. Yeah. So, I think it's important to look at where lung screening has been successfully implemented in terms
models of
of
success.
high volume. If you look back at the initial publication that Ella talked about yesterday, that was published in 2013, we were very clear to have high volume in the title of that paper because of how critical that is to screening lives. I mean, to saving lives when it comes to screening. There's nothing magical about the primary care physicians at Leahy. They have as much work as everybody else does in terms of primary care. And so I think there are certain things that you have to get right. You have to get that message about benefits and harms correct. You need a data tracking system that is dedicated to bringing the patients back in with a navigator who can bring the patients back in the way that we do in mammography. And you need to provide educational materials to your referral base and be able to give patients information in clear language about screening. And I think if you do that, it happens. Let's focus on the things where we have the highest bang for the buck, where we can actually do things, where we've proven that we can do things, and focus on that. Let's figure out a way to get people dedicated management systems, because that's where a lot of this is going wrong.
Okay, we're going to come.
Navigators are being asked to run programs and get patients back in and keep track of all of these patients. And as soon as they get to, 1,500 patients, forget about it. They can't do it because they don't have the software systems to do it. You guys have always had software systems to track your patients in the research setting and get patients back in. If we want to have compliance and we want to have the ability to help our primary care physicians with the screening process, that's what we need. And we also need, I think, better training for radiologists.
Okay, thank you. I think the common thread is we got to make this easier. It's got to be much more fluid. And we'll come back to aspects of that. Thank you, though. I'm still on 2. And I'm going to pick up the pace, I guess. One of the things that I would say, Andrea, in response to your appropriate comments, because, fully agree, is that the software to do this and to get it to play in the sandbox, rather than go one by one, to get it all interacting, that's where a cloud-based resource could be very helpful. And Rick, do you want to comment on what we just talked about 10 minutes ago? A cloud-based integration of tools to potentially help ambulatory sites?
Oh, you mean tracking of
Management
how
system.
radiologists are doing, how
Yeah.
AI is doing, all of that? Yeah, I mean, we're the management systems that we have, probably other management systems out there can do that. And I don't know if everybody wants that information kept because it might reveal some glaring issues. But I say, how are you going to optimize the system unless you track the data, right? So I agree. That's a good thing to do.
Well, and the open source software that they developed through Bristol Myers Squibb could potentially be made available.
It is it is
It is already
completely
available and could be part of a comprehensive cloud-based solution to have a resource that people could plug into if they didn't have any of these other specialized things. And this would be more relevant to small hospitals rather than big systems. But that's an option, but we share your concern.
I think Dr. Stephen Lamb is online.
Sure. You want to read his question?
Oh, please, want to turn on the video? Oh, actually, he just asked, expand ELIC.
ELIC.
Yeah, sure.
ELIC is a wonderful resource that was developed by the IASLC. It's currently a distributed database and computational resource with 7 sites currently participating. Dr. Lamb and 6 other locations around the world are currently housed on the Amazon cloud. And what the exciting thing about it is once the data is inside of it, we have 700 cases in it right now. Once the data is there, we can run an algorithm at the press of a button that runs across at 7 locations or any number of locations around the world simultaneously. So that means that the data doesn't have to actually leave the country in which it was and the region it was collected in. So I know that the IASLC has strong interest in continuing exploring, continuing that system, and Dr. Lamb is a leader in charge of ELIC, and I think it's a wonderful resource, and will allow many sites developing algorithms to test their algorithms against large numbers of cases that are in the same format. The representation of pack years and nodule locations and everything is all standardized. So it is one of the many things, one of the better opportunities we have for collecting global data sets.
Okay. I'm conscious of time, and I'm going to try to pick up the pace a little bit. We've covered the
Hopefully he's
issues of cost to patients was discussed yesterday in cost to healthcare systems, and there were some barriers. The cost to patients, I don't think we actually did a good job on, because if you're got insurance and all this other stuff, it's cared for. Many of the most vulnerable in our society don't have insurance, and there's still very important barriers to not just the screening test, but the downstream workup, the surgical intervention. They have problems with just paying for getting transportation to the facility. So I think we've got to keep working on this, but we'll keep talking about this. The other things we talked about is the approach to population health and how that might be optimized. And there's a couple of strategies that were discussed, and we'll come back to these, and they're important. And one of the things that we thought was very important was the idea of getting advanced practice nurses or some other health professionals involved in trying to do the navigation in a much more fluid way and figuring out a plan. And this is kind of like, Andrea, what you led last time around with ALA, to have models of success in terms of how do you sustain sufficient personnel to do the navigation at different sites. And so we're going to have this follow-up phone call. And Andrea, you didn't hear about this, but I don't think. But Richard Frank had some very important suggestions about doing this relative to CPT coding and whatnot. Bruce had some other comments. And we're going to get a group together to just talk about creating a model for how this could be deployed in other systems, because everybody appreciates that the navigation is a key element of success, and it's a real bottleneck right now. So we'll continue working on that. Next question, is it time to start thinking about the broader health context in terms of tobacco-related disease? A lot of back and forth. I think this is the stuff that's in the slide you can read. We had a lot of difference of thought here. Some people said we got to focus on lung cancer screening. Other people said, you know, these other things are compelling. We got to keep working on this. I would say right now we have this, the most focus, and I may be self-serving in this regard, in terms of following up on what we talked about last year in terms of the intersection of if you're doing lung cancer screening, you got all this emphysema information coming out, and it obliges you to do something. You don't have a choice. And right now, some places are doing a great job on it, but in general, there's nothing published about what's the gold standard for how these people should be managed, what information should be shared, you know, anything like that. And we need to address that because, you know, there's, you know, something like 20 times more people diagnosed with emphysema in baseline scanning than there are people diagnosed with lung cancer. And we don't talk about it. And US Preventive Services hasn't said boo about it. National Coverage Decision hasn't said boo about it. And we're gonna have all these people with emphysema saying, oh, what do I do? And we've heard lots of things, especially from George yesterday, about nutritional interventions, physical exercise interventions that have published benefit that we're not really bringing forward. So there's a lot of work to be done in that space. Okay. So that would be what I would call an intermediate sequential strategy. We focus on lung cancer, but we start bringing in this first thing because there's issues that are raised that we have to deal with anyhow. And then we've talked about really emphasizing coronary calcium imaging in the context of lung cancer screening next year at next year's meeting as a real focal point. We'll see if people agree with it or disagree with it. Please send me emails or thoughts or additional suggestions, but there seems to be some enthusiasm for approaching it that way. If we do next year, we still haven't talked to Bo and Jody about that, but you know, grouping of these tobacco-related disease makes the encounter far less intimidating. Look at these paths. There's a variety of things discussed about how to better approach the educational challenge. And again, I think this health journey concept is something very interesting to pursue. 3 years ago, we had a plenary session presentation from a gamer who was developing games for mental health management. And there's a lot of traction in that field because they make these games that help reinforce mental health counseling and strategies and stuff like that. And it turns out to be very successful, very cost effective. They showed very impressive data. Gaming in terms of smoking cessation is another opportunity. But gaming in terms of all these issues about risk and stuff like that could be a teachable model for training on some of these issues and stuff like that. So there's some innovative approaches that might be considered. The thing we also talked about in terms of this is we've heard about lung cancer screening for COPD and heart disease, but for thyroid and for adrenal masses and this, that, and the other thing. And we kind of come to some kind of systematic approach to these things because, you know, some people think it's great. Some people think it's terrible. Some people think it's a harm. Some people think it's a benefit. And we kind of have to get our hands around it because this radiomics isn't going to go away. And do we approach this as 19 different radiomics challenges to get all these other sites that we can recover from a thoracic CT image? Or do we kind of figure like the Google's people do, where they have a structured discovery approach, where they you know, do kind of discrete steps, and we do that with an eye towards regulatory approval and come up with a roadmap for validation of additional sites to be included in the process of a population-based screening thing. So this is something that we're going to be discussing in considerably more depth because it's a problem that's not going to go away. Any particular burning issues, thoughts, something we missed, something we misrepresented? Okay.
All right.
Rick, you want to go forward?
Yeah, time to put up the technical breakout slides. Technical recommendations. Unless you want me to screen share, I can screen share too.
David, did we do okay?
All right. Looks like we're in business. So this is the home stretch. We only have 2 slides, so it should go quick. Did I hear clap? How do I need that. Yeah. Okay, so here we are. We've got 4 recommendations. We covered first this whole area of AI CT image reconstruction. And while we all saw a lot of potential here, just like we've seen with iterative reconstruction and other reconstruction methods, we feel we're going to need to do a lot of validation. So the physics, the computing, let's just say the computer vision algorithms that will integrate with with those images, the clinical use of those images, and we'll need to do that before these new methods can be recommended. So that was a fairly straightforward, easy consensus recommendation, and not. I would argue that I think we want to do that as soon as these algorithms are in our hands, and I think they're growing very rapidly. So that's the first recommendation. Notwithstanding the possibility of a salmon showing up in the CT scan, we're still very excited about this. The second, we have 2 recommendations around crowdsourcing. With regard to CT photon counting, again, very exciting opportunity here, and clearly at our doorstep at this point. We need to, but we need to obtain fundamental image quality information on these new scanners. There's some publications coming out with some information, but it would be good to be able to get some time on these scanners. So what we want to do is, and I think we can do this relatively quickly after this meeting. I mean, not today, but the next couple weeks, is quickly establish some fundamental tests that we would be able to run on the scanners, and then reach out to literally all our colleagues, put out a broadcast email to everybody we know, if everybody did that, and see how much, whether we can get some time, literally 10 minutes on one of these scanners, and then literally run a few experiments and get the results and potentially publish this information. So that would help us much better understand how well these scanners will perform for lung cancer screening, and we don't want to wait till next year or the year after before we get information like that. So that's one I think that's actionable pretty quickly. The next one is also a crowdsourcing thing. We saw potential for 3D printing nodules and distributing them around the world. So we'll be asking our entire network again, crowdsourcing, this is crowdsourcing recommendation number 2, to contribute high quality 3D scans of challenging small lung nodule cases, like you see on the right. And these will be 3D printed and sent back to all the sites that contributed data. So you send us 1 nodule, we'll send you back 5 or 6 from you and other people. And then the sites will encourage them to scan those nodules and send back measurements with their software, with their methods, whatever they might be. And this data, again, will be shared and published. And we can move on this very quickly. We have the phantoms. Those canisters fit into our phantoms really easily. That's 9 lung nodules that actually turns out to be cancer. They're identical. When I measured those 9, they were within 0.009 grams of each other. So really, there's amazing technology in 3D printing right now, and we're going to take advantage of it. So we should start getting some really good variability error, let's say estimating the error of systems available around the world for measuring lung nodules, and not with ellipsoids anymore, but now with shapes that are literally real lung cancers. Then finally, if you guys remember this precision follow-up chart, the suggestion was that, hey, why not start to add what different protocols would do in this situation? So there's the lung rats protocol, which needs a 1.5 millimeter change to call something, I guess, growing. And we're going to create those charts, and we're going to put, also, I'm going to create a set of, you see the width of these bands in this chart? I'm going to create a set of these based on the data we've acquired from around the world for the last 5 years, which would be coming from potentially hundreds of scanners. So we're going to be able to now start to put some really nice error bars, not just on the volume measurements, but also on the ability to discriminate benign versus malignant with different doubling times. And so stay tuned. If anybody wants to be involved in any of these recommendations, please send me email, send us email, and we'll be sure to include you and give you lots of action items. No, I'm kidding. We'll try to get you to help. And it should be very exciting. I really think we're going to get a lot done with these recommendations. And that is it.
So I apologize. I want to go back to Steve Lamb and make sure that we address Steve's question. But I think Steve can talk. Can we contact Steve?
Sorry.
Hi, Steve. Wow. Did you just
So-
put that on for us?
So I just making a comment about data sharing. So we have this rich resources in ELIC, and as Rick pointed out, we have 700 cases, 2 time points, so 1,400 scans already. It will be good to have more people contribute scans for AI type of research and that we have. Yeah.
Yeah. Thank you, Steve. Anything else?
No. Yeah.
Thanks for joining
Thank
us. Okay. Any discussion on what Rick had just talked about in terms of the technical issues, David?
Well, first I want to thank Rick for his concise review. I wanted to thank Rick for his concise review of his topic.
In contrast to what?
Yeah, it's just an open statement. The second thing, now that we've gotten Andrea to volunteer to donate her database, I also want to follow up because Andrea told me, Rick, that she has access to the photon counting scanner. Oh, the spectral, not the photo. Oh, not the photo.
It'd be great to have it though.
Not the
It'd be great to
photon
have it to
counting,
fill in
okay.
the scanner.
Oh, okay.
You know, we
okay.
can also do
The
some
photon
some-
counting we need, yeah.
So we can do some really interesting things with that, because we can start to
Interoperability.
we can take the resin in the 3D printer and we can add things to it, like hydroxyapatite for bone or for calcium or for other things. So, or iodine or other things. So I just want to point out that let's talk some more, but it would be really good to explore what we can do with energy discrimination. So.
Okay, so I wanted to point out that the other breakout discussion was a democratic one in which we included the comments from all in an attempt to get the wisdom of many. Any other comments, questions, concerns? Bruce, you had a lot of activity around population health issues. Action items that you think are the priority?
It was probably a mistake on my part not to mention the STAR metrics and the HEDIS metrics. And that fits in well with so much of what's going on, and the detailed, different kinds of detailed data flows that we talked about in the reimbursement codes, et cetera, are perhaps indicative of the kinds of detail that are already available in administrative data and could be quickly put to use. So for sure, the HEDIS measures have been demonstrated to achieve results, to expand screening and to incentivize plans to do whatever it takes to get their members screened. So I regret not bringing that out during the sessions, but since you gave me a soapbox right now, I'd like to put that out there.
Yeah, Bruce, thank you so much, because we should have reported that based on our activity last year, this was a concern that was raised. And Bruce, with the leadership of Al Rizzo, took back the concerns. And as a result of that, ALA had made a commitment to work with American Cancer Society on the HEDIS measure activity to actually get the proper administrative groups involved in moving this forward. It's been implemented as a plan, and it'll take a couple of years to complete, a few years to complete, but that's direct result of last year's workshop.
What's the estimated time frame?
American
10?
Cancer Society is involved.
But what's the estimated time frame? Oh, that was a joke. I got it.
It's unclear to me. They're saying 5?
5 year, it's a 5-year contract.
Okay.
So that's one thing, but in addition to that, and related to what Bruce just talked about, there's another dimension of this that could fit into a STAR metric, which could be potentially executed much more rapidly. And ALA has also agreed to move that forward as well. And the timeline for that, Bruce?
That's on the order of 1 year to demonstrate feasibility. I'm one of the skeptics of EMR-based studies of the uptake of lung cancer screening, because I think the denominator of eligible population is going to be not information that can be reliably obtained from EMRs or anything else.
And especially with the disparate communities that are participating in screening, the ambulatory environment is places where EHR penetration is much less, and it's much less in places with greatest health disparities. So this is a real important screening equitability issue.
It's that, so the yield rate, and I know Dr. Vishani was on earlier panel, had published a paper which actually developed, it wasn't the main point of the paper, but he actually developed a yield rate that is what portion of the diagnosed lung cancers, the incident lung cancers, happened after were found through screening. And of course, the higher that number, the better the outcomes. So that's something that's easily calculated, and we've seen some numbers, and I think Leahy looks at that as well.
Make some assumptions to figure that out, but yeah,
Okay.
never gonna have it totally perfect.
Yeah.
I just was saying, it's not an easy thing to calculate. We make some certain assumptions to try to figure out what that is so that we can have some understanding, but.
Well, it's real easy to calculate in a closed system, which is what insurance companies are.
We're gonna look for.
It's hard to calculate the imputed attributed lives or something like that for a provider system.
Right.
But so I guess there's going to be more discussion on that. By the way, we were talking about this for the 2 previous sessions. We had speakers on HEDIS and STAR metrics for the previous 2 years.
Yes, so, persistence pays off. Persistence pays off. Jody, any comments?
Incrementalism.
I have many comments, but I'm trying to process it all. So one of the things that I am thinking about in terms of, I've heard a couple times throughout the discussion, how do we advance this? How do we move on this? Is really thinking carefully about how we move forward and considering picking a few topics to really dive into as a group. Because I feel like any one of these issues that we're talking about today could comprise a whole day of conversation. So that's what I'm thinking about.
Yeah. So I agree with you, but this is a convening thing. So like the HEDIS measure and STAR measure, which comes out of this, Bruce is going to be working with some of the policy people from ALA and stuff like that. So it leverages some bandwidth that, isn't necessarily restricted to the people in this room. By the same token, there's some other things that we've discussed where we can bring in other professional organizations. I think Al is going to help us with Javier and George in terms of management of emphysema findings that are typically called out on screening. And again, that's going to bring new blood, new bandwidth into this. And I think we should constantly, and some of this stuff we can go back to Kiba because there's some Kiba specific issues here. We've heard from Steve and Rick about what can be done with the ISLC. I think we have some real great things to follow up with the VA. So I think pulling in, trying to delegate some of these things to other organizations can amplify what this group can potentially bring in as work scope so that we do distill stuff that we actually do something about or achieve something with, okay? So I share your concern, and that's part of this, processing of the data that we've heard over the last couple of days, over the next couple of weeks, and bringing it back out and communicating to these various groups, both here and into our virtual community, because this is urgently needed in so many different arenas. But your point's very important. David, you look poised to speak.
No, I just want to thank Rick for his concise.
I wanted to
Little joke, Jim.
I wanted to thank you
So I want to
for providing a model of the perfect male. That was heroic.
thank you. Like I said, no shame. I think there's a lot of things that could come out of this. The idea of those databases and how we can pull them together. And, the idea that we can define normals and this is a great area to pursue. The topic that I challenged or threw down the gauntlet for that within 5 years, we're going to have a product. This is a big topic. I'm not kidding about that. And I think this this organization here can be very much a part of seeing that happen. And I'd love to make, that a focus of, our next meeting. That should be a big part of what we're doing and how we can really make that get out in the world, because that kind of a product is going to draw in other products to go along with it. And I think the idea of pulling together some of these databases that exist by members here, including, people listening in on the other end, Steve Lamb and his organization. There's a lot out there that, it's a meeting, but it's almost more than a meeting. It's a group of very committed workers. It's really a group of very committed researchers that seem to be very willing to work together. And so long as we come up with, a focus to move forward with, I think we'll pull in a lot of resources.
Okay.
You have it here intellectually resources, but other resources will come as well.
Okay, well, that's wonderful. And, the action plan we had in terms of having a call Richard Frank and Bruce and some other people about, figuring out ways to sustain resources sufficient to get more navigators on board, we will address shortly after this meeting. And after we have a game plan intact with that, I think we go back to PCORI and try to have the workforce discussion. And if there's people in this room who want to be involved in that discussion with PCORI, or there's anybody on the call, that's great, because they did this for the workforce needs for the aging population. And then they had some very important programs that they put in place for professional development to address those needs. So there is a good precedent for that. Any other final comments? If not, Bo, I've been told that you were going to help us close.
Bring it into the harbor.
Rick said we're already in the home stretch. We're stretching home stretch.
So I opened with a lot of thank yous. I now close with a lot of thank yous. Starting with Jim, because he is our fearless leader, and without him and his vision for this meeting, we wouldn't be here for the 19th time. So Jim, I think we all owe you a little applause. All the speakers, you were wonderful. I think we are all leaving here with our heads spinning, but other than that, we learned a lot. And I also appreciate the efforts of all the steering committee, because without you and your willingness to get on those conference calls every 2 weeks, almost year round, we wouldn't be doing this either. So thank you for that. Adrian, Liz, Stacy, you all are just brilliant, and we would not be having this meeting without your meticulous attention to detail. And to all our friends from the Blue Ridge Event Production Company, we wouldn't be having this meeting so successfully without all your time and talent. So thank you, and please tell Bill we send our best and hope his family is out of the COVID woods pretty soon. I don't think anybody's still here from Awesome Games Done Quick, or rather Games Done Quick, but we really appreciate the fact that they came and conducted such really spirited interviews. I can't wait to see the final products. We'll share them with you and they share them with us. And once again, even though they aren't here to hear it, we very much appreciate everything, all the work at the foundation that's made possible by those donations that take place over a week in January. And I would encourage you to watch it, and you can even make a donation yourself. And finally, it's really important to acknowledge the fact that I've had a long list of our staff who were involved in the meeting, starting with Jody Hoyos, our president and COO, who's still here. And but I think there are at least 7 or 8 more named, and so everybody pitches in. This is a really a joint effort, and I think it's fair to say it's a labor of love. And finally, I would like to close just by saying one more time, congratulations to Andrea, and thank you for sharing such an inspiring story with us, and all those who paid tribute to you, Ella, et cetera. Thank you too. So I was quick. I wish everybody safe travels, and hope to see you next year. Thank you.
Okay, I'm ready now. Okay, so the one thing that I would add to the thanks is that our sponsors, Prevent Cancer Foundation and the American Lung Association, have been unbelievable in allowing this forum to keep moving forward. And so I think, I don't think we have to, I think everybody will give one final round of applause for it. So thank you very much. Safe travels. And any feedback at all, please fill out the forms, and anything else, please email to us, and we read them all. Very important that we hear from you. Thank you.
All right.